Good morning. Today I'm going to talk to you about the hype, the hope, the reality, and a vision for the future of genomic medicine. I'm not sure when my vision will be realized, but I'd like to share with you some opportunities we have for the future. I'm going to talk about 3 different use cases we have in terms of genomic diagnostics. First, that is the case of diagnosing a patient who's already symptomatic. The second, a case of an individual who is not yet manifesting any condition, but yet for predictive testing. And the third, for population-based screening. We are able to do all of these things because of the decreased cost of sequencing, but I would argue that we still have improvements to realize in terms of what we can do to drive down that cost, and I'll show you some examples today. First, I'm going to start with the use case in terms of screening, the case of non-invasive prenatal screening. It's really a remarkable improvement that we've had compared to the old days when we were doing first trimester serum screening. Shown here are the graphs in terms of sensitivity for some of the common aneuploidies. But even more remarkable to me is when you look at the positive predictive value, for instance, for looking for trisomy 21, and how much better we are with the non-invasive prenatal screening. Look, for instance, for younger women below the age of 35, and how much better it is to be able to have this as their test for screening. I'm going to now move to a second use case, that of diagnosis for someone who's symptomatic. I had the pleasure of meeting a family with a 9-year-old little girl who had had seizures from the day that she was born. It was a really bittersweet experience for me because although we were able to make a diagnosis, in her case of a glucose transporter 1 deficiency, it came at 9 years of age. The reason why it was bittersweet is that if we had made that diagnosis for her instead at 9 months of age, 9 weeks of age, 9 days of age, or even better, 9 hours of age, we would have had a completely different outcome. The reason being because she had had a lifetime of seizures by 9 years of age. By that point, she had already had cumulative damage to her brain that resulted in irreversible brain damage, intellectual disabilities. By knowing that her deficiency was a glucose transporter, that she couldn't get glucose across the blood-brain barrier, we were able to think very quickly in terms of how to be able to treat that. Instead of using glucose as her fuel source, simply switch her to fatty acids, give her a ketogenic diet, and as we did so, completely abrogated her seizures, but yet could not reverse her intellectual disabilities. This was my call that we had to do better. We had to be able to make those diagnoses earlier within that disease course. So how rapidly can we do that? I would argue at the first time of symptoms is our opportunity to intervene. Sometimes that will actually be in the neonatal setting. We have the opportunity to make those diagnoses in days for our babies in the NICU. We can even push it farther forward. In the prenatal setting, we sometimes even get the first glimpse that there may be something with that fetus. And we have the opportunity to be able to make those diagnoses so that when those babies come out the chute, we know exactly what we're doing. We know the diagnosis. We know the other associated findings so that we can look for them and we can prevent those complications. We have the ability to give parents the opportunity to wrap their heads around that diagnosis, make their mental adjustments, seek the best practitioners to take care of their newborn, make sure they deliver at the right hospital. We have the ability to do all of these things. As we think about this with increasingly genomic tools, exome sequencing, genome sequencing, we need, however, to be rigorous. We need to think about the use cases for which this is the appropriate tool. And I'm showing here what the clinical yield is, the chance that we would find a diagnosis for several different clinical indications. This was a series that we did, and actually these cases are already 3 years old. And in many cases, these individuals had already had previous testing, 2, 3, 4, 5 genetic diagnostic testing tests prior to exome sequencing. So this, to me, represents a minimal yield in terms of what we can expect. And you can see that for many indications, congenital hearing loss, congenital blindness, the yield is 50% or greater. Even for many neurological conditions, neuromuscular diseases, autism, intellectual disabilities, epilepsy, yield of 20 to 25%. So as we look at this, there are many cases in which we can effectively make a diagnosis. But yet, we are still in a state of flux. There are still things that we need to learn. And in particular, when it comes to variant interpretation, we have not solved all of this yet. This is data that we had from the Clinical Sequencing Exploratory Research Network, where we took 99 variants, gave them to 9 different clinical laboratories shortly after the new ACMG guidelines came out, and we asked them to actually look at those variants and do an interpretation. And in fact, in 22% of cases, there were clinically significant discrepancies between the laboratories. Circumstances in which one laboratory may have identified or classified the variant as a VUS, another laboratory classified it as pathogenic. However, all is not lost. By getting those laboratories together, by getting them to discuss why there were discrepancies, by getting them to share data, in fact, there was significant improvement. At the end of the day, they reduced that discrepancy down to 5%. But yet, even with the same data, even using the same criteria, there was still 5% discrepancy. I would argue that what that means to me is that we are still in a state of flux, but we are on the road to improvement. So as we think about how to do this, we need to think about systems, automated platforms to be able to push out automatically variant reinterpretation as these variants are reclassified, as we get more knowledge to be able to bring that as quickly as possible to patients and to their providers. But the problem is not simply about single variants. In fact, it's a bigger problem when we think about an entire exome or a genome. There is still much that we have to learn. In this particular series, when exomes were originally identified, the yield was approximately 25%. But fast forward 3 years later, with all of the information we had learned, for the 75% of cases that were originally exome negative, up to 50% of those cases either had a new definitive diagnosis or in fact something that suggested a candidate gene. So again, we are in a state of flux. We need to be able to have opportunities for families to be able to realize that new information. We need to think about new models where patients can actually have that data and perhaps by a subscription service be able to get iterative reanalysis over time. Subscription service so that the individuals who do that reanalysis actually get paid for what they are doing to do this, but that families can again get their diagnoses as quickly as possible. As we think about this, there is still much that we have to learn. There are still many improvements we can make in interpretation of exomes and genomes. There's still better that we can do in terms of everything from being able to go to long-read sequencing at some point, being able to understand and do better alignment, identify certain difficult variants such as difficult insertion deletions, better interpretation of variants such as missense variants and in-frame deletions, being able to get better interpretation because we have more data. We have more ethnically diverse data, and finally because we have more functional data to directly assess some of these variants. So as we do this, though, we need to have evidence also to ensure that these services get paid for. And we're a bit of a chicken and an egg situation. To be able to get enough data and enough outcomes, we need to be able to scale this to much greater extents than what we are doing now. Yet to scale this, who is going to pay for this until we have the evidence to demonstrate the clinical utility? For those of you who are funders in the audience, I would argue that we have started this process through some of our research studies. Through things like CSER, Ignite, we have just begun to gather that evidence. But we need to do this on much larger scale, and we need to do this in a rigorous method using research tools to be able to do this. And so for those of you who are funders, private or public, I would argue that we need to do more of this on larger scale. Potentially, all of us may give us some of the opportunities to do that. But I would also say to those of you who are researchers doing gene discovery efforts, we also have an opportunity in that space to gather some of these data. So for instance, one of the studies I'm doing, SPARK, a genetic study of autism, we have 50,000 families on whom we are doing exome sequencing as well as genotyping, and we are offering as part of that process the return of individual results through a CLIA laboratory and studying the outcomes in terms of what the impact is of having that diagnosis. And by doing that, adding that dimension, which in terms of marginal cost is relatively modest, we will be able to generate the necessary evidence we need to demonstrate the clinical utility. What we are doing now is simply a small drop in the bucket of what we can and should do. However, we are going to need ways to scale this using the limited resources we have, the limited number of genetics professionals we have to be able to deliver that. We are going to need to be more efficient and have more things to enable us to do more. So what models can we use? How can we solve that problem with the limited workforce that we have? I'm going to start at the center of this circle in terms of generating the data. By consolidating our sequencing efforts, by having a smaller number of laboratories around the country that can generate genomic data, I would argue that we can do it much less expensively, much faster, and much higher quality. And this is something that we can realize today. In addition to that, with cloud-based computing, it is relatively easy to upload that information to a cloud for whomever needs to analyze that data, and to be able to do so pulling in data sets, whether they be other research data sets, clinical repositories, from federated data sets in the cloud, and be able to use that to improve the interpretation of that information. By having those as federated data sets, we can still honor the original consent of participants and patients and be able to share that data in a maximally effective way. As we do this, we can also build and share platforms and methods of analyzing those data. So we can scale this and we can iterate in a much faster timeline. We can have interfaces so that analysts around the world can be doing this and bringing the entire workforce to bear. In addition, we can use resources such as ClinGen that have already accumulated within the community experts, so that if you see a particular variant that you don't have much experience with, you can phone a friend. You can get some advice from someone who has deep expertise in that gene to understand whether or not that variant is likely to be important, functional, pathogenic, and relevant. And by doing this, we can scale this all, again, to improve quality, to decrease turnaround time, and to decrease cost. In addition to that, though, we need to be able to scale what we can do in terms of education of the public. What we do in terms of counseling needs to actually be counseling, not simply spending our time doing education. Angelina Jolie did a remarkable job of doing this, but for a simple use case of BRCA1. With her New York Times editorial, being able to share her experience, raise the public consciousness about BRCA1 and what to do with that information, and allowed this to become a public discussion. But how can we do this on a much broader scale? We should use some non-conventional ways to be able to communicate with the public, whether it's television shows like Grey's Anatomy, whether it's TED-like talks like this, or whether it's even curated, well-designed educational materials that we put on a dedicated YouTube channel to educate the public, individuals in college, high school, even middle school, to bring up the genomic literacy of the community. As we do this, for instance, for hereditary breast cancer, we need to do a much better job of risk stratification. What we have done with BRCA1 and 2 was a very good beginning, but it is not nearly enough. We realize this is much more complex. We are already testing, for instance, for moderately penetrant genes, but we even have the possibility of looking for modifiers of BRCA1 or 2 or a polygenic risk score. And as we do that, we need to aggregate all of that information together to come up with accurate risk prediction models, but include not only genetics, but also include, for instance, family history, other modifiable risk factors such as BMI or alcohol intake, and do that over the life course. Be able to deliver real-time risk over the next 5 to 10 years, even using biomarkers like mammographic density. As we do this, we need to be able to provide this information in a way that is meaningful, digestible, comprehensible in real time. And we as the genetics community have the unique ability to be able to take that evidence-based medicine and put that into actionable items. To take those act sheets, but now that we have electronic health records, to be able to disseminate that in a much more effective way than we have ever had before. By doing this, we can build platforms, and now that the medical community is converging on EPIC as an EHR, be able to build this once and disseminate it very broadly. Being able to use that evidence basis to be able to give guideline recommendations, interventions that are going to be effective, and to do that with just-in-time delivery so that providers can use that exactly at the moment when they need to make decisions. And even better, we can continue to update that, push it out as we gain new evidence so this continues to be dynamic. But as we do this, this cannot only be a provider-facing interface. Even more importantly, I would argue, we need to build a patient-facing interface simultaneously. Something so that patients can have an app on their telephone so that they can digest, they can understand, and they can act on that information in concert with us. They can take the genetic information and understand what their health threats are in real time and be able to make prioritized decisions. Be able to support those decisions, though, by giving them real-time feedback in terms of how effective they have been in terms of that modification. So, for instance, if diet and exercise or weight are to be interventions that are effective, be able to count how many steps they've taken, be able to monitor their weight over time, and see how that bends their curve in terms of their risk. With this, they can also disseminate information to their families, a very effective tool to be able to cascade out on that genetic information. And I would argue that the other opportunity we have, which is to me the most exciting, is to get beyond the diagnosis. Get beyond the diagnosis and get to the treatment. For spinal muscular atrophy, this is to me one of the most amazing strides forward that we have made within the last year. The ability now to use oligonucleotides with an FDA-approved medication, and even looking at the phase 1 clinical trials of gene therapy to see how AAV9 is going to offer us a one-and-done treatment for what otherwise was the most common genetic cause of death for children less than 2 years of age. Seeing this and seeing these opportunities, we started a newborn screening pilot study in New York State because we realized this was a degenerative condition. If we waited until the time these babies were symptomatic, we might have lost our window of opportunity to have maximal impact. So we started a newborn screening program in New York State to be able to detect children. This was the first baby that we identified. She was identified to have 2 copies of SMN2 and predicted to be a type 1 SMA, to be able to have a lifespan that would be measured in the matter of months. And as we treated her, starting at 15 days of life with nusinersen in a clinical trial, she was able to take her first steps at a normal time. And I'm glad to tell you that now at the age of 2 years, she is a strong, healthy toddler with completely normal milestones who is indistinguishable from her peers. And these are the opportunities that we have. As we're doing this, I urge you to keep patients at the center of this. They keep us grounded. They keep us thinking about what's practical, what's doable, what's important, and what matters. And they can be a very powerful force in terms of moving things forward. So in closing, some of you are going to look at this picture and see this as a sunset. A time where the chapter has closed and when things that what you've done in the usual way are ending. But I urge you instead to look at this as a sunrise. The opportunity to do things in a completely novel way that will allow us to scale genomics, to deliver genomic medicine to many, many more people who need it, to offer the opportunity to get beyond the diagnosis, to get to the treatment, and to do this much more effectively. I want to close by thanking those who have helped me prepare this presentation, Julia Wynn, Vulcan Okor, as well as Alana Chilton. Thank you.